So let's go on and get started. And you all should have gotten a notification just now that this session is being recorded and it will be shared later by the Texas Mood team on their YouTube site. Well, good afternoon again, everyone. Welcome to the Support Hospital Opioid Use Disorder. That's Shout, Texas Echo. We're so glad to see all of you here today. For those of you newly joining, again, note that we are recording these sessions to make them available later. My name's Andrea Roche. I'm here at UT Health San Antonio with the ECHO team, and I'll be facilitating today's conversation. A few quick announcements before we begin. There's a large group today, so we won't do introductions of all participants, but please, to help us with our record of attendance, we ask that you enter your name, your affiliation, and your email into the chat. If you join by phone only, which I don't think anyone is, we may call you after the session just to confirm attendance. Again, this is just for our own record, but we do appreciate you helping us keep a accurate record of these sessions. We love to see everyone's smiling faces, or maybe not smiling faces, during today's session, especially during the discussion portion. So we encourage all of you to join by video if you're able. That said, we're happy you're here, even if you stay off video, even if you're calling in. So thank you. We encourage everyone to speak to and share their perspectives and their experiences. If you're new to Zoom, to do that, to mute and unmute, if you've joined by computer, you select that microphone icon on the bottom left corner of your screen. If you've joined by phone only, or you're joining with your phone to support your computer, it's a *6 with a bit of a lag. Again, please remember, in these sessions, no PHI is allowed either in the chat, in the case presentation, or in our discussions afterwards. Texas Mood is recording these sessions. We'll send out the link in a little bit for where you can find all of those sessions on the Texas Mood YouTube page. And again, after the session, Texas Mood will send out an evaluation, a link, to a post-session evaluation. We really appreciate your feedback on that to help us shape these sessions. Today's didactic is about naloxone prescribing and distribution in the hospital, presented by Lucas Hill. Thank you, Lucas. Following that, we're going to have a case presentation, but let's start with some introductions of our hub team. And following that, we'll do our didactics, some announcements from the Texas Mood team, and the case presentation, and then our open discussion. All right, so let's turn to Chris, if you could start with introductions. I thought I saw him join, and then maybe I saw somebody else. How about you, Richard?
Yes, hi everybody, welcome. My name is Rich Botner, and I'm an assistant professor of internal medicine at the medical school. Welcome.
Thank you so much for being on. And Blair.
Hey, I'm Blair Walker. I'm assistant professor of psychiatry at Dell Medical School. Welcome.
Thank you. Jan.
Hi, I'm Jan Ramesh. I'm a hospitalist at Dell Medical School.
Thanks for joining. And to our didactics presenter, Lucas.
Hey, y'all. Lucas Hill, clinical assistant professor at the UT Austin College of Pharmacy.
Thank you so much. I'm looking around in my screen. I don't think Chris has been able to join just yet, but we will ask him to introduce when he's able to. Veronica, you're our case presenter today. Can you introduce yourself?
Sure. Hello, everybody. I'm Veronica Perez, an addiction psychiatrist at Baylor Scott & White in Temple, Texas.
Thank you. And Esther.
Good afternoon, everyone. I'm Esther Gomez-Wilkson, Community Outreach Coordinator for Texas Mood, and supporting today's Shout Echo.
All right. I think I've got all members of our hub team. We'll troubleshoot with Chris, who's working to connect right now. But in the meantime, I'm going to turn things over to you, Lucas, if you can go on and share slides and take us through your presentation.
Absolutely. Hey, well, thank you all for being here, and thanks to Rich and Alana for the invitation. I know that distribution of naloxone, while I think a lot of us have a handle on the general concept, especially in an outpatient environment, there are a lot of questions and nuances potentially to distribution in the hospital, and just a need for resources, some orientation to what resources are available, what has already been done in this area. I tried to mine some available publications of programs that have functioned in the hospital. frankly, none of them addressed most of these questions about the actual process very well. So I'm going to present to you from basically my perspective as somebody who has been running state-funded naloxone distribution and education programs in Texas since the Naloxone Access Law was passed, and who implemented in 2013 to 2015 a co-prescribing program out of 3 outpatient family health centers, and helped to set up some of the early phases of naloxone distribution out of emergency rooms at the University of Pittsburgh Medical Center as well. So I guess I'm going to ask you to rely on my expertise to inform your institutional approaches, because there are a lot of gray areas, to be entirely honest. And I'm going to start with the presentation with a little bit of an orientation to some pertinent data. I'll try to skim through it, but I want it to be available to you just so we're on the same page about the role that opioids are currently playing in overdose deaths and kind of how we want to frame this for patients. So another heads up, I just want to disclose that I did spend 4 hours on a community advisory board call for a drug company a couple of months ago that was developing a new formulation of naloxone, which is now available, and I will address later in the presentation, but I think you'll find that my opinion was not swayed by the small amount of money that I made out of this experience. And by the end of the session, hopefully you're going to be able to do these things, but I'm going to jump in and try to move fast, and we'll have the case and opportunities for Q&A. And I lost my mouse. Okay, here we go. So y'all are familiar with the triple wave opioid crisis, the concept of movement from prescription opioids to heroin to illicitly manufactured fentanyls. And you're probably familiar with the concept that now in some parts of the country, fentanyl and fentanyl analogs have entirely replaced heroin. We're not there yet in Texas, but we do seem to be moving gradually in that direction. And fentanyl analogs are not the only potent synthetic opioid adulterants in the US drug supply. My colleague Claire Zagorski, who's on the call today, wrote a commentary several months ago about isotonitazine, has also alerted me and others to a few other drugs like etonitazine and some other newer synthetics that are not detected by fentanyl test strips, but that are kind of similar in potency and effect to fentanyl analogs. And so this is going to be a whack-a-mole experience where there's going to be no end to the number of potent synthetic opioids and other non-opioid adulterants in the US drug supply, like xylazine, that have really unique negative effects, and some of which increase the risk for acute respiratory depression and death. So the problem's not going anywhere. And I also would like to address the statement, which I think we all agree with, at least to some extent, that this problem is not just opioids. But I want to give kind of a counter argument and say it is still mostly opioids, at least if we're talking about acute overdose deaths. And so when you look at graphs like this from the CDC, these rising overdose deaths that include cocaine or psychostimulants like methamphetamine, a person who dies with multiple drugs responsible for that death is going to show up on multiple lines of this graph describing which drugs were responsible for the overdose. And it is quite plausible that many of these deaths have sort of circumstantial inclusion of cocaine or methamphetamine. There are several qualitative studies, and we've just finished collecting data for another, looking at people who use illegal opioids and maybe often are exposed to ultra potent opioids. I don't love that term, but potent synthetic opioids like fentanyl, really unintentionally, but it's what they can get their hands on, and it provides a more potent and more sedating effect that they don't necessarily want. So amphetamines and cocaine are often being used to counteract that sedation by people who need to be able to function in their day-to-day life. They might have a job and they need to function at their job. They might be unhoused and they need to be able to protect themselves and their belongings, so they need to stay more alert. So it is unclear to what extent these substances directly contribute versus just happen to be present along for the ride during acute overdose. but there's no reason to think that we've turned the corner in any way on opioid-related overdoses, or that specific emphasis on opioid reversal in the context of acute overdose is something that we don't still need a really substantial emphasis on. Breezing through some of this, but I would like to point out too for y'all that while there is some evidence that problematic drug use, alcohol use, other substances, and solo use have increased during COVID, there's plenty of evidence that drug overdose deaths were rising well before COVID. And in Texas, overdose deaths actually started to rise back in September of 2019. So I don't think that even if we do get a handle on COVID, which we have shown no signs of any ability to do, especially in Texas, I don't have any reason to believe that that would have a really appreciable effect on our trajectory related to drug overdoses. Another graphic depiction of the rising prevalence of synthetic opioids. And then even in Texas, where we know we've got some data limitations, the prevalence of fentanyl and other synthetic opioids and drug overdose deaths is rising rapidly. Whether that's because it's actually penetrating the market in a new way, or this is just because people know to look out for it and it's being detected more often, is unclear. It's probably some mixture of the two. The fact that we have black tar heroin as the predominant form of heroin here is probably somewhat protective, though again, our qualitative surveys of people who use drugs show that they do sometimes mix the two, black tar heroin and powdered fentanyl, and that's they also perceive that they are being exposed to fentanyl increasingly. Probably the biggest limitation to the data we have in Texas is the fact that 239 counties are not covered by a medical examiner. So if you die outside of a healthcare setting, a justice of the peace is likely to be certifying your cause of death. And there are certainly limitations to somebody without substantial medical training, and sometimes with problematic disincentives for municipal spending of funds to thoroughly work up a cause of death. We know it's easy to mistake a drug overdose death for something else. So the predominant approach in the US response to the drug or opioid related crisis thus far has been supply reduction interventions, which had pretty predictable unintended consequences of pushing people first from prescription opioids to heroin and then from heroin to illicitly manufactured fentanyls. And we're still certainly seeing pressure to implement these in various settings, mandatory checking of the PMP, for example, and targeting of prescribers who are prescribing high amounts of opioids or have patients at high doses, which can lead to pressure to get people off even when it's not appropriate. So what I'm encouraging you to think of as a hospital, instead of focusing primarily on opioid stewardship programs, on programs that prioritize, the most important outcome being the number of milligram morphine equivalents that a person receives per day, or the number of new opioid prescriptions sent on an outpatient basis, potentially contributing to long-term use. Instead of those being your primary metrics, I would encourage you to think more about not only how you can expand access to medications for opioid use disorder, but how many naloxone prescriptions are you providing? How many doses of naloxone are you directly distributing? And what are you doing as a program to hand off to local harm reduction coalitions or to provide syringes directly to people who maybe, now that you're offering a more compassionate and evidence-based approach to opioid use disorder treatment, are willing to be more candid with you about the fact that, well, I'm really only down to do bupe while I'm inpatient, to not go into withdrawal, and I'm not going to go to that outpatient clinic meeting. So how are you going to prepare them for the reality of their return to use upon discharge, and plan for that appropriately? But we're going to focus on naloxone. So I anticipate that y'all are familiar with the concept of naloxone as an opioid overdose reversal agent. It's a potent mu opioid receptor antagonist. It will, when administered by laypersons in an intramuscular or intranasal formulation, it should reach opioid receptors on the brainstem and displace opioid agonists within 2 to 3 minutes. Certainly the relatively high dose formulations that are available and currently preferred for layperson use, a single dose is going to be sufficient even for a highly potent opioid agonist. And the risk for adverse effects is incredibly minimal. Anytime you give one of these presentations, especially in first responder groups, somebody will chime in and say, well, what about pulmonary edema and flash pulmonary edema? Okay, well, what is a adverse effect of acute opioid-induced respiratory depression and lack of breathing? Flash pulmonary edema. And so there's actually not evidence to support that naloxone is inducing that. With naloxone, we do need to worry about opioid withdrawal syndrome. And the higher the dose of naloxone, the more likely we are to precipitate a really florid withdrawal, really uncomfortable and agonizing experience for somebody who spends in many cases, pretty much all of their time trying to avoid opioid withdrawal. So that is a scenario that people aren't excited about entering, and naloxone can precipitate it, especially at high doses. And the higher the dose, the longer the duration of action is going to be. So even though the half-life may be the same, if you're falling from a higher peak concentration, it's going to take longer to wear off. I don't have much in here about kinetics, but I would point out that a single administration of the high-dose Narcan nasal spray 4 milligrams is going to maintain a plasma concentration that is higher than the peak of a good old 0.4 milligram IM dose for at least 3 hours. And it is likely to be effective for even longer. It also means it's likely to induce withdrawal for that long, and people need to be educated and prepared for that situation. In Texas, we do have a Naloxone Access Law, and it's one of the more liberal or comprehensive naloxone access laws in the country. So it allows for pharmacy-based access without a prior physician encounter. It allows for third-party prescribing to people who might witness an overdose, so you don't have to prescribe just to the person at risk, but also to a friend, family member, or frankly, based on the definition, anybody who says they're interested in having naloxone. And then it has broad liability protection for health professionals and overdose responders, even layperson responders. So if you administer it wrong or you forget to tell somebody about a key education point, it's okay. We know that you're doing your best, and you don't really need to worry about being held liable because you delegated naloxone distribution responsibilities to somebody on your team who doesn't normally have a lot of interaction with medication use processes, like a social worker, for example, or a chaplain. Anybody can do it. In addition to being important to distribute naloxone to people with an opioid use disorder or who are actively using opioids in a non-prescribed manner, there's really strong evidence that if you distribute naloxone to people on chronic opioid therapy for pain, you're going to prevent emergency department visits and hospitalizations. And the number needed to treat of 29 is pretty impressive. So let's talk a little bit about Texas-oriented resources. If you go to the Texas Opioid Training Initiative website, txoti.org, I'm going to show you a few different key resources here. One is our free CE programs. So everybody on your team could easily access a free 1-hour program that goes into more depth on the way that naloxone works in an overdose, and is appropriate even for non-medical people or people with very limited medication knowledge. And it hits a lot of the key points that you need to hit when you're educating a patient or a friend or family member about how to respond effectively with naloxone. So not required in order to distribute naloxone to take this, but I very highly recommend, and you'll have a familiar presenter who is very excited about the topic. Then there are a variety of other clinical resources that we've developed, and I'll shout out to Shout and the B team for really being the impetus for these specific materials. So a badge buddy that helps to quickly remind your team about who needs naloxone, what are the key indications and risk factors, as well as an MME chart, which I'm going to be honest, I don't spend very much time thinking about MMEs. If the concept that this person might even remotely be at risk for an opioid related adverse event, or might know somebody who is, even crosses my mind momentarily, I'm going to offer them naloxone. And I think that having the lowest barrier to offering it is important. I don't put a whole lot of stock in the like Ryazord or these other scoring algorithms. you spend a lot of time on it. Just the idea of even having to do it makes a lot of clinicians think, oh, I don't want to get involved with this. Why is prescribing naloxone so complicated? It's not. Just give it to anybody. And then here is a kind of a fancy, beautiful concept from Rich and Alana, to be able to hand a patient something that looks like a prescription, even if you're not actually prescribing naloxone, to just say, hey, here's where you can go in the hospital on your way out to pick up this thing. And the power of giving somebody a written prescription, as you know, I've been taught before in the context of writing out a prescription for a diet or an exercise plan or whatever else you might want. It's got that little extra impetus beyond just giving them education. There are a couple other documents inside of our operational naloxone packet at the website that I think might be of interest to you. One is this patient education handout that includes a specific checklist so that you could check off, these are the reasons that I think you should have naloxone. It helps to externalize or decrease some of the potential conflict and say, look, here's a kind of a rigorous peer-reviewed document that says you might be at risk and why you should have it. It's not that I think you're doing anything wrong. It's not that I think you're a bad person. These are just key risk factors, and maybe somebody else will get into it in your house and you could keep them safe. And then there's also some guidance about how to write a prescription for any form of naloxone. I will say, if you are prescribing naloxone, Narcan nasal spray has won the war. This is the formulation that's by far the most likely to be at the pharmacy. And so it's probably your safest bet as far as getting it to somebody. You can also, though, go to either our website and this Get Naloxone button, or directly to a website called morenarcanplease.com. And you can get free naloxone funded by the state, facilitated by a team led by Dr. Lisa Cleveland at UT Health San Antonio. And if you make a bulk order, like 108 boxes, then you're going to get that medication shipped directly from the manufacturer. And it's going to take 4 to 6 weeks, but you're going to know where it came from. You're going to have this substantial supply of free Narcan nasal spray that you can then distribute to anyone you please. There are a variety of ways to operationalize this in the hospital, but I really think that the simplest way to do this is to mostly take the prescription and, in many cases, the pharmacy out of the process, because there are very specific regulations and labeling practices that need to be followed when you issue a prescription. And there become challenges with how to maintain separate stocks of Narcan, one that came from this free charity supply, state-funded supply in one part of the pharmacy, and the stuff you save for people who get a prescription in another part. And that can add some complexity. So my recommendation is that you go to the website, you get an order of free Narcan nasal spray shipped to you as a program. You encourage anybody who's going to be involved in the distribution and patient education to complete that 1-hour free online CE. And you develop some sort of protocol. It doesn't have to be a signed standing order. A standing order is not necessary at this point, but some sort of process whereby you've written down this is how a patient's going to be identified and informed and provided with naloxone. And this is how we're going to document in the chart that they were educated about it and that they received it, or that they declined it this time, but we're going to remember that and offer it again next time. So come up with some sort of process. To be a little more specific on the standing order and prescription issue, basically, in order for the medication to get out of a pharmacy or to get out of the manufacturer's hands and into the hands of a program that requests it from this free state-funded website, a standing order has already been issued. A prescriber has signed a standing order, and you have received that shipment under that standing order. It was prescribed to your organization or your institution. Now you don't need any prescription or standing order, because anybody who has naloxone in the state of Texas can transfer it to anyone else. Now, being in a healthcare institution, oftentimes legal, and I love pharmacy, but pharmacy get real antsy and want to throw up extra roadblocks. And I can try to connect y'all and share materials from the Network for Public Health Law, but the reality is, all you need is some sort of protocol saying this is where we're going to keep the medicine. We're not going to label it. We're going to distribute it through this mechanism to people who need it directly. And that is going to be the most expedient way to avoid needing to send people down to the pharmacy, needing to maintain a separate stock, needing to have them wait until the pharmacy gets it ready and distributes it, and all the related confusion. If your team can just have a supply and hand it directly to people, you're going to save lives, you're going to save time, and it's going to be better for everybody. So open it up for questions and just close by saying that distributing naloxone from the hospital ED has incredible potential to prevent overdose deaths, and you do not need, you don't need to have a specific prescriber or pharmacist provide education. Any team member can distribute naloxone. Just have some sort of protocol and get your free supply from morenarcanplease.com or the free naloxone request button at our website.
Thanks so much, Lucas. I'm seeing clapping hands. I'm seeing an amen in the chat. I want to hear about those. I want to hear from those clapping hands and that amen. Any questions, any comments about this presentation?
So this is Dustin out of JPS in Fort Worth. We've had some definitely some barriers from a pharmacy and P&T committee standpoint on naloxone, yes, and also we have some restrictions through our P&T committee that have limited our ability to empower some of the primary teams to prescribe buprenorphine even to inpatients on the medical floor. And so the roadblocks that are being put up elsewhere definitely resonates at our institution, and we're working with Rich and their team to help put together some educational material to reduce some of these barriers and roadblocks at our institution.
I will add that I didn't refer to it previously, but there is a document developed back around 2015, 2016, when the Naloxone Access Law was passed in Texas, developed by the Network for Public Health Law. It's linked under the clinical resources on our txoti.org website. And it has a little bit more information about some of these nuances of who can distribute naloxone and those issues. But I will admit, again, that there's some gray area. Unfortunately, when laws are written, you'd think they'd be written really clearly and intelligently, and that our lawmakers would be just true leaders in these areas and experts. And unfortunately, that's not the case. So I think that I will admit that you have to reconcile with the interpretation of your local risk management and legal department, which tends to be, we can't do anything that isn't explicitly legally stated that we can, when that's the opposite of the way laws operate, and it's that you can do everything that isn't explicitly stated that you can't, but that's not their view, and I'm not a lawyer. I will say too, there are alternative approaches that you can take that maybe would help allay some of the concerns of your legal department, like Del Seaton Medical Center, where Kirsten Roberts or Mason, I can never remember which one's the current, is helped to implement a workflow diagram whereby the outpatient pharmacy would first evaluate whether a patient was funded and could afford their copay, and if so, they would process and they would go from their conventional prescription stock of Narcan, and they would dispense that following a typical labeling process. And if a person was unfunded or could not afford their copay, then they would pull from this separate charity stock, and it was a way to have a protocol and to store that medication in the pharmacy. There's not necessarily a clear right way to do it, but whatever you need to do in order to start making this happen is what you have to live with at a local institution level.
Thank you, Lucas. Any other questions? All right, well, while Echo IT is pulling up the announcement slides for the Texas Mood program, I'm going to ask another one of our Hub team members, Chris, could you introduce yourself?
Yeah, hi everyone. My name is Chris Morades. I am a practicing hospitalist and I'm Assistant Dean for Healthcare Value and Associate Chair for Quality and Safety at Dell Med School at UT Austin, and I work with the B team in Shout, Texas.
Thanks so much for joining. All right, Esther, I think you see your slides. And when you're ready, tell us what's going on with the Texas Mood program.
Thanks so much, Andrea. Yes, so thank you again for joining us today at this Support Hospital Opioid Use Disorder Treatment ECHO, also referred to as the Shout Texas ECHO. Texas Mood is the largest training and technical assistance center for focusing on SUD in Texas, and we act as a one-stop shop for those working in addiction treatment and recovery services. Next slide, please. Texas Mood offers education, training, resources, and research for the SUD healthcare workforce. Our clinical services are focused on expanding access to compassionate, evidence-based treatment and recovery support services for the uninsured. We are building and supporting statewide telehealth initiatives for those impacted by COVID-19 and for regions affected by natural disasters. Our telementoring efforts aim to improve the quality of care and expand our skills treatment workforce across the state. For many, these trainings mean the difference between life and death, active addiction, and recovery. Because we as Texas Mood are hosts at UT Health San Antonio, we focus on clinical research to develop cutting-edge treatment and disseminating them into communities throughout Texas. Next slide, please. Support Hospital Opioid Use Disorder Treatment, or SHOUT Texas, is a program at Dell Medical School at the University of Texas at Austin and UT Health San Antonio's Texas Mood that is working to increase access to substance and opioid use disorder treatment and harm reduction during acute hospitalization. SHOUT's mission is to expand their proven model of hospital-based treatment of OUD to all hospitals in the state of Texas. To do that, SHOUT has developed a robust collection of education and coaching opportunities, including a monthly ECHO series, which you are attending today, our monthly general office hours, bi-monthly OB focused office hours, and an expansion pilot program, which can include $35,000 in seed funding to start similar programs at hospitals across the state. Next slide, please. We hope you can join us at our next Shout Texas ECHO set for Thursday, September 16th. We'll hear from Dr. Lori Harper on women's health and SUD in the hospital. You'll see we do have a QR code on this slide to register for the next session. At the end of today's session, we will have this slide up again to give you an opportunity to grab that QR code to register. Alana from our Shout Texas team will also drop a link for registration later on in the session. Next slide, please. Texas Mood is excited to introduce our Heroes Helpline for all first responders and healthcare workers. This also includes all allied health professionals. It is absolutely free and provides complete confidential telephone-based peer support and referral services to all first responders and healthcare workers in Texas. Our heroes have the opportunity to seek treatment without fear of judgment or stigma or occupational dilemmas. Screening and referral interventions assist individuals in overcoming barriers, addressing their mental health needs, and navigating them to treatment and recovery. We invite you to visit the heroeshelpline.org website for more detailed information. Next slide, please. You may sign up for all of these Shout Texas educational opportunities I mentioned via the shouttexas.org website. The next round of pilot site seed funding will be opening in the fall. If you or your organization is interested in this funding opportunity, email the Shout team to get connected at shouttexas@austin.utexas.edu. Next slide, please. In our continued ongoing effort to provide you better services and support, we would like to request your feedback about today's session. We will be providing a link in the chat a little later and also will send it to you via email. You only have to submit the survey once. And as a reminder, the survey is also how you will receive your CEU credits, so be sure to fill that out for your credits. We thank you for your support and we hope to see you next month. Thanks, Andrea.
Thank you, Esther. IT read my mind. Well, so while we are pulling up the case presentation for today, just any questions from the group? All right, Echo IT, I'll ask you to go on and share the PDF. Veronica, tell us more about this client. We'll be sharing the information you presented. Feel free to tell us to scroll up, scroll down, go faster, go slower, whatever helps with your presentation. Take it away when you're ready.
All right. Again, I'm Veronica Perez. So this case that I'm presenting is an outpatient who was seen inpatient She is a 60-year-old woman, and you can scroll down. So she was seen in the emergency department for fever, a large abscess to her right proximal thigh. They were attempting to IND it in the ED, but she couldn't because of the pain. So they ended up admitting her, and then she got the IND in the OR. So just a brief background. She has a history of IV drug use, primarily heroin, has also used cocaine as well. She had another visit less than 30 days with an abscess on the other thigh, secondary to IV heroin use. At that visit, she had been able to discharge from the emergency room on antibiotics. So back to her ED visit of the case we're presenting today. So she had pain, fever. Her last reported use of opiates was a month ago, is what she said to the emergency room physicians. They did not collect a urine drug screen. And so past medical history, she has a history of heroin use, hep C, remote CVA, and then residual right-sided hemiparesis in a seizure disorder. Also left breast cancer history, tobacco use, and then the recurrent abscesses that we see in the presentation. Here's a list of her home medications: Topamax, pramipexole, anastrozole, and mirtazapine, buprenorphine, naloxone, suboxone. She's on 16 milligrams daily. And then she has been prescribed the naloxone actuator. She actually had used it at the visit after her last visit in the ED. She had followed up and had ended up acknowledging the use of the naloxone. So just she had a refill on it, so she got the refill okay. Well, while admitted, these were the medicines that she was given while she was admitted for this the abscess that she had. She had a course of antibiotics, a bowel regimen for constipation. They continued her home meds, the mirtazapine, pramipexole, and Topamax. They did not continue her Suboxone. And then they were giving her PRNs for Norco, the 10 Q4 hours, and then Dilaudid 0.25 Q5 minutes, and some morphine was also in there as well. Upon discharge, she was given the antibiotics to take home, but wasn't given any prescriptions for opioids. And that was confirmed with the PMP review as well. They did not mention anything about her Suboxone. So some social history: she lives with parents who are older. Her son is a primary support system. However, he just got married and moved to Dallas. So he goes back and forth. Her plan is to go live with him in Dallas once he and his new wife get situated. And so that was that's been a factor in her mood surrounding this incident. She had also lost her best friend in a car accident. So some triggers there for relapse. She is pretty independent and functional. She drives herself to appointments, although her son has helped her and does help her whenever he's in town. And she's not working, she's on disability. So psychiatric history, opioid use disorder, severe dependence. Her depressive disorder, she's never met criteria fully for MDD. She does come in with depressive symptoms, but it's kind of hard to know, is it secondary to her substance use, because she has had multiple relapses. At the beginning, she would relapse almost on a weekly basis, come back, get on Suboxone, do well, then relapse, and kind of that pattern until most recently we had gotten her a little bit more stable until the loss of her friend and her son moving out of town. And then she also struggles with insomnia, nicotine dependence, and then a history of cocaine abuse. Cocaine hadn't come up recently on the urine drug screens that we do in the outpatient clinic. So just a summary of her hospital course: she was admitted for IND, given IV antibiotics and PRN opioid pain management. Her Suboxone was not continued while she was in-house, and there was no urine drug screen collected. No red flags that I noted when I checked the PMP. I didn't see any mention of the PMP during her record review. But she usually is very forthcoming and will acknowledge her relapses and work on it. At her last visit, we had even got her into a brief outpatient kind of rehab treatment that she was motivated to go to as well. So some of the questions, and then just at the bottom is just her substance use history. Primarily was heroin, but she does have a history of cocaine, nicotine, and cannabis. So the questions that I'm presenting today are just that kind of review or open for discussion best practices of communication between inpatient and outpatient providers, any experiences with the 42 CFR Part 2 limitations, how do we ensure, I'm not sure why she went to Baylor Scott and White Hospital facility. And so we all use the same system, of course, Epic, and I'm an outpatient provider, but I wasn't aware of her hospitalization until she attended her follow-up with me. So what were the reasons that I wasn't involved, or that we collaborated or talked about this, what to do with her Suboxone, or just, her presentation there, her pain management, anything like that. And last month, we kind of touched on how to encourage continuing buprenorphine while the patient is admitted. So that's also something open for discussion as well. And then I guess the third thing, maybe to consider any thoughts or feelings about them not collecting a urine drug screen. It would have been my preference if they did that, because this, she comes in with another abscess on a different site from her last visit less than 30 days ago. She does have a history of other substance use. Is there something else that we should be mindful of? So those are kind of the questions that I'm bringing up today, and any thoughts or best practices or experiences.
Thank you so much, Veronica. Echo IT, you can stop the screen share. That was a really thorough case presentation, and thank you for bringing such a challenging case to us. Like Veronica said, let's open this up to the community. Any questions or thoughts about this case today?
This is Jim Ditchin. One concern I had was that was a second visit to the emergency department. What we're pushing for at JPS as well is using the screening, brief intervention, and treatment when accepted. So the second visit could have perhaps been avoided had they been screened and started on buprenorphine at that time. Also, perhaps second abscess, etc. So I'm really a big advocate of starting as early as possible in that connection with healthcare, and often that is in the emergency department.
Yes, I agree, and she was already on Suboxone. She was my outpatient patient, so she does get Suboxone. And she was on it. And when she comes to outpatient, we test in the clinic. It's no charge to the patient, so I can tell if she's taking it or not. And she's been compliant. Despite her relapses, she's still compliant with the buprenorphine Suboxone. And I was just wondered why they didn't continue it if she had been on it, or it wasn't even mentioned in the history of present illness or anything like that. So just how to encourage that, how to encourage her to continue it, even if she was going to receive additional opioid PRNs for pain management. How come they didn't continue the Suboxone?
Veronica, I have a couple of thoughts, which is, as a hospitalist, unfortunately, a lot of the issues that you've pointed out are not at all specific to opiate use disorder or to this problem. As you know, we've struggled mightily with any sort of communication and coordination of care for all of our patients, essentially. You point out here many of the pitfalls with that. You would have easily been able to tell the story, ensure that she continued on her buprenorphine, naloxone. If you wanted a urine drug screen, because it would have helped inform your care in the outpatient setting, you could have done that. So it's really hard. We've worked on many projects, once again, unrelated to specifically our B team work, around coordinating care with primary care providers. And I wish I could say that there's something that has emerged locally or nationally that seems to consistently work. but there hasn't. I mean, in some systems, like when I was a resident, the vast majority of our PCPs were within the same closed system. And so we would email upon admission. And, you know, we were able to do that securely, and that worked really well. And we had an expectation, and we tracked and we gave feedback. That doesn't happen now. But I wanted to point out, I think, that you bring up 42 CFR Part 2, and I think it would be great for us to talk a little bit about that. And I know we do have some experience and thoughts about that. But I think that's optimistic to even think that that came into the play here. I would put any amount of money on the fact that that was not the consideration. Right. That it simply is, we fail to communicate with our PCPs. We just look at the problem at hand, the abscess that needs to be treated. You know, we oftentimes say it's like pumping up the tire, not looking for the nail. It's like abscess treated. I know how to treat that, antibiotics, and then send them out. And the fact that they didn't mention opiate use disorder in the assessment plan also, unfortunately, is common. Like, they've studied this. So oftentimes we mention it in the HMP. It shapes, unfortunately, the studies show, our attitudes and our behaviors towards the patient, but does not shape our plan. And so they didn't have a specific plan. And I wonder, in some ways, you know, you said that she wasn't continued on discharge. And I would guess that just means they didn't prescribe it. But it, once again, is probably a sin of omission rather than commission. Like, they didn't tell her to stop. They just didn't even address it. So anyhow, I don't know that that's all that helpful, but to normalize the problem, we can talk a little bit about 42 CFR Part 2, which I pretty much learned from my friend Rich. So I appreciate you bringing up this topic that we can all kind of discuss. So I'll start the conversation based on what I've learned from Rich, and then others can probably chime in, which is, if you're not familiar, this is a regulation that, as we understand it, really came about to protect patients. It actually was a very patient-centered regulation. Because back in the 70s and 80s, there were practices of law enforcement and others accessing records within methadone clinics and other treatment centers in order to then inform warrants and to go after folks. And so these protections were put in place specifically so that this information basically couldn't be used against patients, particularly recognizing the stigma related to OUD treatment. Two things that we should note is, first, it's a regulation, not a law. So what that means is it's within the executive branch, right? So it can change based on the interpretation, and the execution of this can depend on the current administration. And it predates by a lot HIPAA. So some folks will say that it's no longer necessary since we have HIPAA, and we all are used to HIPAA. Others will say it's stronger than HIPAA, so we still need it. The bottom line, though, is this: like, the point was, first, if we think about the spirit of the regulation, it's protect patients. Not coordinating care, not communicating does not reach that goal at all, right? So the goal of making sure that we're not allowing law enforcement and others access to records is very different than saying we can't pick up a phone and call a PCP and communicate care, which, you know, HIPAA, 42 CFR Part 2, all of that does not prevent any of us, as, you know, clinician to clinician, picking up the phone and coordinating acute care for a patient. I think that's the first thing. And the second thing that's kind of tricky is that 42 CFR Part 2 really applies apparently to those that hold themselves out as a treatment center. So like those that basically hang a shingle and say, I'm a methadone clinic, and in this situation, we're not. We are treating an abscess. We're treating acute medical care. And therefore, we're not a treatment center. And so it shouldn't even apply to us. I'll kind of pause there. I will state the disclaimer that Rich gave and probably is about to give, which is, you know, we're not lawyers. This is not, and so I can just speak as an individual. But I would tell you that 42 CFR Part 2, from my perspective, should never stop us from picking up the phone, calling, or even our normal practice of coordinating care if it were to send a secure email through, you know, or a secure Tiger text or whatever system y'all might be on.
Thank you. I appreciate that and agree with everything you said. And this was before we really got into the Shout initiative. So another reason why we're bringing it to our facility, because we have a lot of work to do. And like you said, it's not just us, it's everywhere. So I think just putting out the education, introducing myself and who I am, and just being available so that people know, because maybe they don't even know that I'm here or what I do. So thank you for that.
Yeah, I said nothing works, which is pretty pessimistic, but that is I should say that is the thing that works, which is relationships. You know, when people know Dr. Perez, they are much more likely to pick up the phone to call you to, connect with you. So that is key. It's just a little bit of it's not very system based to say I'm going to go make sure I have a beer with all the hospitalists, but that works.
Hi. Hey guys, I'm Emily. I work in Houston at Bentop Hospital with pregnant women with substance use disorder, and the CFR stuff has come up with our work with CMS and the maternal opioid misuse grant. And same, the legal compliance folks at our hospital were like super like, oh my gosh, like we have to get a hold of this. And it's true, we do need to talk through it and make sure we address it. But really, in the context of us working with substance use and residential treatment centers or community centers that do treatment, we're not disclosing any new diagnosis because we are coordinating the care for the same purpose. So kind of like normalizing that we're all like actually working on the same diagnosis together. We're not disclosing anything new, in the same concept of HIPAA, but specifically related to substance use disorder diagnoses. So I was just going to throw that out there. But the other thing, and I know this is not like really fun to say, but because we have the same thing. So we work in a big hospital system. We have Epic, and it's like we have or could have had access to the information when our patients go inpatient, but we miss it all the time. And so one of the things that I've worked towards is really using the tools to make them work for us. And so I actually do create patient lists so like you could create a patient list for like in Epic. Do y'all use Epic where you are, Dr. Perez?
Yes.
Yeah, so you could create a patient list of all your patients that are on buprenorphine treatment, and then you can get alerts and check your lists, and you can actually tell if your patient has had a recent encounter inpatient. And again, it's not always best because it's not necessarily promoting the provider calling you or knowing to call you, but I actually think it puts it on us because we are the primary care team anyways. And so it just creates another opportunity to not miss, that opportunity to then we can reach out to the inpatient team. So it's just another thought. It's not as great as I agree, like having a beer with our team members and other parts of the system, but I think it also helps.
Thank you. I guess I'll have to get more familiar on how to create a list.
Yeah, it's easier than you think, just so you know.
That's some great practical guidance. Thank you, Emily. Claire, you put something in the chat, and I wonder if you might unmute. You're raising actually a question I was going to ask, which is continuity of care if this patient is going to be moving to Dallas soon to join her son.
Yeah, and just, I'll admit right off the bat that this really isn't any kind of a proximal solution to what's going on here, kind of echoing back to Dr. Moriarty's, we can pump up the tire or you can look for the nail. And looking for the nail is probably going to be a long game with a lot of our patients. So this is indeed pumping up the tire so we can kind of keep ourselves in better health for the time being. But yeah, there are groups in Dallas, Houston, Austin. There's a small kind of nascent one in Waco that tries to stay under the radar because of legal reasons. There's some in El Paso, but they do community-based teaching, a lot of teaching on how to inject safely, on how to inject safely, not only to avoid things like phlebitis or vein damage, but also to avoid skin and soft tissue infections, which are truly out of hand here in Austin. I know that much. But there's a group up in Dallas, and more than happy to connect y'all with. They will keep her flushed in Narcan. They'll give her safer use supplies. And if she's just coming up on an issue where she's running out of veins, and I see a lot of skin and soft tissue infections really get out of hand when people run out of veins and start shooting into the soft tissue. we can figure out other ways to avoid some of that. There's just a lot of teaching we can do where we sit down with folks and talk about ways to avoid issues. Just a couple of weeks ago, I got on the phone with a resident in Baltimore who wanted help figuring out how his patient who dropped his lung going for a subclavian could figure out a better way. And we did, we figured out a better way. So he's not going to try to stick a needle in the top of his chest anymore, hopefully, because he was in the hospital on a chest tube, no fun. So yeah, there's just kind of networks all over the state, and legal issues keep a lot of them kind of under the radar, just because if you attract attention locally, the police can kind of go after you for possessing paraphernalia, because when we collect used syringes to be incinerated in that time period between when we have them and we have them incinerated, we're technically possessing paraphernalia because it has drugs in the syringes. And of course, that's a legal nitpick, but it happens sometimes. People go after us sometimes. So yeah, you can always reach out to me. I put my email in the chat a couple times, but try to find, groups in your community. They can take so much burden off of the hospital systems with doing like teaching, preventive care, helping people with short-term, just getting to the next step, helping people find maybe outpatient solutions instead of letting things get bad enough that they need to be admitted for 10 days on an IV or something. So yeah, I'm a huge fan, and this goes back to the getting a beer with your hospitalist thing. Do what you can, and I know this assumes endless time, right? But do what you can to try to find like your local community workers and support groups can really, many hands make light work sort of a deal.
Thank you, Claire. I'm wondering, I know we're quite short on time here. I did want to quickly, you bring up about how to continue during hospitalization. We did talk about that in the past a bit, but a couple of quick thoughts and maybe we can open up real fast and finish up in the next couple minutes. But I think first, if it's really just continuing a medicine that someone's already on, it really comes down to comfort, education, and familiarity. So that's going to happen as people first prescribe it and they realize this is just like continuing other medications and they should do that. This situation is a little different because continuing it in the setting of acute pain management, and they have she was admitted for acute pain, right? Because she couldn't tolerate this abscess range. And so in that situation, we can get into specifics, but we don't have time today, I think, to go into, and we can talk about this during Future Echo further about, different strategies to do that. But the overarching strategy, I think, is knowing someone to call. So I just wonder, particularly as you all roll out at Baylor Scott and White there, if folks know who to call to get some advice about, should they split the dose? So I would call Blair, Dr. Walker, and I'd be like, hey, should we give, TID dosing here? Should I lower the dose and give opioids on top in the short term? Should we hold it short term, but not just because I forgot to put on the assessment and plan, but because I'm consciously choosing to do that? So that's the key thing, is making sure you all have identified somebody that people know they can call for guidance.
Right. Yes, I agree. And it's happening. I had a surgeon call me the other day for one of the patients on Suboxone, how to continue it while their surgery. And so yes, we'll get there.
Yeah.
And thank you, Claire. I will reach out to you.
And that's the specific, thing, is to make sure you get that out wide and that everybody feels like that's a low barrier that they could reach out to you and get advice about what to do.
Thanks so much, Chris. I'm going to ask Echo IT to go on and share that slide with the QR code for joining our next session, and thank Alana for putting the link already over there in the chat. Chris, any other thoughts to wrap up our conversation, some key points to keep in mind?
Well, I'll just hit up a couple, key points. So just as summary and review, we heard from Lucas, I think, a really great presentation, get us all up to date around naloxone. Takeaways that I heard was prescribe to anybody who wants it, and that we are pretty well protected in doing that. Try to remove all possible barriers and give it directly to people whenever we can. And he shared very specific resources on how we can do that. And then, talking through this case that Dr. Perez brought, thank you so much, brings up many different issues around, but a lot of it really is around communication and community building, I think. Making sure that the hospitalists know who and how to contact our outpatient providers, that we're trying to coordinate care, and then ensuring that we're creating some familiarity with buprenorphine naloxone therapy so that folks continue it during admission, coordinate after discharge, and then the tricky issue of CFR Part 2. But I think we're all in agreement it should not get in the way of us having clear communication, particularly, clinician to clinician.
Wonderful. Great wrap up. Thank you so much, Chris, for being our lead specialist today. Thanks to the Hub team and to Lucas for your presentation. Veronica, a huge thank you to you for sharing your case and your knowledge today. And thanks to our community of practice. We hope to see you again in September. Have a wonderful rest of your week. Bye-bye.